Good morning, everyone. Welcome to the second Retina Imaging Conference of the academic calendar. My name is Abtin, Shahlaee, and I'll be starting off today's cases. Our first case is a 34-year-old gentleman with sudden central vision loss in the left eye. Dr. Light, could you walk us through this one?
Happy to. So this is a gentleman in the right eye, 2020, wide field pseudocolor imaging of the right eye. Media appears clear. The disc appears to have sharp margin 360, maybe roughly about a 0.3 cup to disc ratio. The vasculature appears to have normal course and caliber out to the visualized periphery, the macula itself without lesions or hemorrhages, and I don't see any lesions in the far periphery either. In summary, a normal appearance.
Excellent.
However, in the left eye, where the vision is unfortunately count fingers, the media overall looks clear, maybe a slightly hazier than in the right eye. The disc itself, again, has sharp margins here, no disc hemorrhages or edema. The vessels appear to have normal course and caliber out to the visualized periphery. There is notable retinal whitening in the peripapillary and macular region here, kind of fairly well circumscribed. There is also either hyperpigmented or possibly subretinal hemorrhage here in what appears to be roughly the subfoveal area. And then in the near periphery, there's also this linear whitish lesion with what looks like might be subretinal hemorrhage adjacent to it. However, the mid and far periphery appear grossly normal.
Perfect.
This is an OCT horizontal raster scan through the right eye, again, the 20/20 seeing eye. Aside from a little bit of some reflection artifact here on the IR, image looks normal on FOSS. The OCT scan itself shows healthy appearing, kind of relative normal appearing choroidal thickness. The outer retinal lamination patterns are intact throughout. The inner retinal lamination patterns are also of normal thickness and pattern here, and there is a healthy thickness to the retinal nerve fiber layer in this eye, essentially a normal scan. In the left eye, again, the count fingers eye, this is again a horizontal raster scan through the fovea. I'll start, first of all, in the on-FOSS imaging, you can see this well-circumscribed area of hyperreflectance on the IR corresponding to the borders of the retinal whitening we saw on the pseudocolor imaging. On the OCT scan itself, notable for some vitreous opacity here with these hyperreflectant foci. The inner retinal border shows some irregularity, and there's some blunting of the foveal contour here. There is still an intact retinal nerve fiber layer. The inner retinal lamination patterns look intact, albeit a little bit distorted in their course here. But however, when we get to the outer retina, you can see that there's marked attenuation of the outer retinal layers. There's in fact almost nearly complete loss of the outer nuclear layer, the ELM, and then the outer retinal bands, including the ellipsoid zone, and even marked attenuation of the RPE layer here. And there appears to be possibly some hypertransmittance in the areas of RPE loss where we see more signal in the choroid than maybe would be typical. Subfoveally, there's this hyperreflective focus of material, whether it be blood or pigment, and then adjacent to it, there is a small sliver of subretinal fluid, and then there is shadowing artifact into the choroid underlying this.
This is a vertical cut.
Yeah, again, very similar findings here, vitreous opacity. There's marked attenuation of the RPE with probably some increased transmittance into the choroid here. Inner retina overall is relatively intact.
So I haven't really given any history, but what would be your kind of broad differential for such a lesion?
Yeah, so acute onset vision loss with profound outer retinal loss, RPE involvement, and then also a focus of possible subretinal hemorrhage. I think the first thing I would be concerned about might be some sort of a traumatic insult. Maybe this is a type of commotio, and there's a focus of choroidal rupture out there in the nasal periphery. Other things, though, that could cause outer retinal attenuation. Think about some sort of inflammatory or infectious process. For example, a placoid syphilitic lesion can cause marked outer retinal loss in kind of a well-circumscribed area. So I'd want to know a little bit more about maybe sexual history, exposures. Other things that could cause, probably less likely, but like a chronic CSR picture could cause some outer retinal abnormalities, market atrophy, especially if it's been ongoing for a long time. However, it sounds like this was relatively acute vision loss, so it would probably be unlikely. The area of retinal whitening could suggest some sort of an ischemic process. Didn't look like a classic CRAO picture, but I would also want to know about history of hypertension, diabetes, smoking, other medical comorbidities. And then, you could also consider other sort of inflammatory, like white dot syndromes, where there can be loss of outer retinal layers. Doesn't look like MUDES or AMPI, but again, could at least consider those. And then maybe finally, some sort of a degenerative process. I don't know what the refraction of this patient is, but high myopia can cause marked outer retinal loss, RPE changes. Maybe that little subfoveal focus could be a small amount of CNV that's starting, and then other dystrophies or hereditary conditions that can cause outer retinal loss. I would also consider.
Great. So you kind of hit on all the important ones that we were thinking about as well. Definitely traumatic was highest on our differential for this patient, and I think we went over all the other ones here as well. What other further history items would you inquire about this patient?
Yeah, well, as I mentioned, I think I'd like to know if he had a traumatic insult first and foremost. I'd also like to know more about any medical comorbidities, history of hypertension, diabetes, other potential sources of vascular compromise. Whether or not he's had maybe viral prodrome, which could be suggestive of some sort of inflammatory or white dot syndrome. And then maybe a refractive history. Does he have a known history of refractive amblyopia with high myopia in that involved eye? Or is there any family history of retinal dystrophy or degenerative condition?
I have one more question. Was he minding his own business?
Good question. We're going to get to that right now. So the patient was indeed involved in a motor vehicle accident earlier that day of presentation, and he had an airbag injury to the left eye, the eye that it was affected, and he presented to the emergency room essentially with a traumatic hyphema and vitreous hemorrhage and was found to have those retinal changes. So our diagnosis here was commotio retina with an area of choroidal rupture, and this condition essentially is a traumatic retinopathy, which is secondary to either direct or indirect trauma to the globe. It could be either in areas of coup injury or scleral impact, and also in counter-coup sites, distant sites, including the macula, such as our case. When it's in the posterior pole, it's also called Berlin's edema, kind of termed by Dr. Berlin in the 1800s. And it's usually in the setting of a closed globe injury or a blast injury. And about 1/3 of patients with all sorts of ocular traumas presenting to the hospital do have some evidence of commotio retinae. In terms of management, it's usually observation, and most patients actually have a fairly good recovery with minimal sequelae. However, there could be permanent vision loss or associated scotoma in severe cases. And more importantly, we should monitor for other comorbidities or ocular comorbidities that these patients may have, namely macular holes of traumatic nature, retinal tears, choroidal ruptures, such as what our patient had, subsequent CNV formation, lens changes, hyphema, evidence of glaucoma or cataract formation later on, sequelae of orbital fractures, and chorioretinal atrophy, which may result. There's not good literature as to use of steroids in these patients, but I was wondering if any of the attendings would consider steroids in any particular scenario for these patients.
I don't think there's any evidence for it. At the molecular level, I think it might make sense, but I think that's probably secondary inflammation. By the time you get the injury, your photoreceptors, RP, is just shot for these cases with severe macular commotio. And OCT is a fantastic way to kind of prognosticate. Before OCT, fluorescein was a good way. If there was a lot of leakage on the fluorescein, you knew the patient was not going to do good.
Glad you brought that up, Dr. Inakawa. So in terms of prognosis, there's this good study by Anna and colleagues looking into retrospectively at 59 patients with macular commotio, and they came up with this kind of grading based on OCT in terms of the severity of the disease and the prognosis, where, as we see, grade 1 here refers to basically thickening of the inner digitation zone, where normally we would see this kind of sliver of hyporeflectivity at that area. We see hyperreflectivity, and this is grade 1. Loss of the interdigitation zone would be grade 2. Loss of the interdigitation and ellipsoid zone would be grade 3. And loss of interdigitation, ellipsoid, and external limiting membrane would be classified as a grade 4. And as you can see, structural recovery is guarded the higher the grade is. Also, regards to visual prognosis at month 1 and final, as we see, the more severe the grade, the lower the logMAR and visual acuity, to the point that in grade 4 disease, we basically don't see anyone with 2200 or better visual acuity, so guarded visual prognosis there. And this kind of matches our patient's course as well. So he actually presented a week before the initial images that I shown, was noted to have profound macular edema in addition to the outer retinal changes. And by the time we saw him, already had kind of outer retinal loss, pretty profound, count fingers vision, and up to 2 months on follow-up, kind of still has those persistent outer retinal changes and no recovery in terms of central visual acuity.
So what grade did you call him?
We thought he was a grade 4.
Yeah, because all 3 are missing.
Okay, jumping into the second case. This is a 47-year-old.
Comment. With the choroidal rupture, you also have to follow for choroidal neovascular membrane. So we got to follow that, not right away, but maybe 3 to 6 months later, some of these patients will, start up with choroidal neovascular membrane. So the vision can be good initially, and then they can lose vision from the choroidal neovascular membrane, which they may need anti-VEGF, especially if the choroidal rupture goes peripapillary area or in the macular region.
I'm curious, how often do you follow these patients initially after the acute injury and presentation?
If I see them initially, if it's hyphema, it's a little bit different. You want to follow them a little bit closer. But if it's, Berlin's edema, you probably will bring them back in 4 to 6 weeks and then 3 months. But if there's a choroidal rupture, you may follow them a little bit closer.
Perfect. Our second case is a 47-year-old gentleman with intermittent painless vision loss in the right eye for about 4 days. Dr. Sivalingam, could you walk us through this photo?
So here we have a pseudocolor wide field fundus photo of the right eye. Vision is 20/25. Media appears clear. Looking at the disc margin, you can see kind of this blurred disc margin, 360 degrees, with this circumpapillary flame-shaped hemorrhages. Looking at the vasculature, diffusely, the arteries, more so the veins, appear dilated and tortuous in their course and caliber. And then we can see these kind of diffuse, what appear to be intraretinal hemorrhages, kind of in this blot-like pattern in the periphery as well as in the macula. Hard to say if there's any thickening or macular edema. Vision's pretty good, so probably unlikely. I don't see any frank retinal whitening or any peripheral vascular abnormalities out in the visualized periphery.
Great.
And here we have a color fundus photo of the left eye. Vision is 20/20. Media looks clear. Disc margin looks nice and crisp. Cup to disc ratio, probably around a 0.2. Vessels appear normal in their course and caliber. Maybe a little bit of tortuosity, but less so compared to the right eye. Macula looks clear. I don't see any hemorrhages, no retinal whitening, and the visualized periphery also looks fairly normal. Maybe a few little areas, these little nonspecific lesions. Hard to say in this photo if it's just kind of pigmentary changes versus a little hemorrhage here. And here we have a fundus autofluorescence image of the right eye. Again, we can see this redemonstration of these kind of dilated and tortuous vessels. The disc margin also appears blurred, correlating to that disc edema we saw in the color fundus photo. And then we see these areas, these diffuse kind of blot areas of hypoautofluorescence that seem to correlate with those areas of hemorrhage that we saw in the color fundus photo. And here you can kind of see this normal, more hyper autofluorescence concentrated around the macula. And then we have fundus autofluorescence image of the left eye. Appears fairly normal. Again, we have these kind of areas of hypoautofluorescence. Not sure they exactly correlate to anything that we saw on the color fundus photo.
Yeah, and that posterior pole hyperautofluorescence is also present here, and it's pretty symmetric, so that may be a normal finding. That's what we assumed.
Sure. And here we have an IVFA image of the right eye. We're at 17 seconds here. You can see kind of this lobular choroidal filling. We still have some areas here where it's hyperfluorescent, but we're still pretty early on. Appears to be early arterial phase here. Maybe some, what looks like possibly a cilioretinal artery filling here. And here we're at 23 seconds.
Excuse me, Mary, did you see like a leading edge of dye here for slow perfusion? Jose or Dr. Civilin?
Looks like, for 17 seconds, there is some early leading edge of dye, but it doesn't correlate with the vision.
And here we are at 23 seconds, full arterial phase. Maybe even some, it's hard to say for sure, maybe some very, very early venous laminar phase. We can see kind of redemonstration of these areas of hyperfluorescence that correlates to those hemorrhages that we saw before. I don't really see any frank leakage. Macula looks okay. I don't see any leakage here, but we definitely need to see more images. Maybe some, if you go back, maybe some very early hyperfluorescence around the disc here as well. And here we are at 29 seconds. Appears to be AV phase, although you do still see some laminar flow here along the inferior arcades. I don't see any frank leakage in the periphery. It looks okay. Again, maybe some slight leakage around the disc here, and macula looks okay. So here we are at 34 seconds. AV phase still, but interestingly, you still see some venous laminar flow here, kind of inferiorly and inferonasally here. Persistent kind of hyperfluorescence around the disc. Again, in the periphery, I don't see any frank leakage, and macula still looks pretty good.
Here's a later frame.
Yeah, so here we are at 6 minutes, and we kind of see this diffuse hyperfluorescence. Looks like it's mostly around the veins, kind of correlating to this diffuse leakage. And then again, you see this kind of diffuse hyperfluorescence around the disc as well.
This is the earliest frame we have in the left eye.
Sure, so here we are at 1 minute and 7 seconds in the left eye, full AV phase. Appears fairly normal. Again, we see this kind of subtle tortuosity of the veins here, but disc margin looks good. I don't see any leakage, and macula, I don't see any hyperfluorescence correlating to any leakage, and periphery looks fairly normal. And again, later frame at 6 minutes and 10 seconds looks fairly normal as well.
Don't really see that disc leakage that we had in the fellow eye.
And here we have an OCT horizontal scan through the right eye. First, looking at the infrared image here, we kind of see this redemonstration of what we saw before, these dilated and tortuous vessels. We see this blurred disc margin here that we saw before, and these intraretinal hemorrhages, again, that we've been seeing in all these images. Kind of going top to bottom, the vitreous in the OCT scan itself looks nice and clear. I don't see any hyperreflectivity. Looking at the nerve fiber layer here, kind of closer to the disc nasally, you see this kind of undulating pattern, possibly correlating to some folds that you may see on the fundus exam. And then you see this area of hyporeflectance, maybe correlating to some intraretinal fluid, possibly tracking from the nerve, correlating to that disc edema. And then looking at these interretinal layers here, you can see these kind of focal areas of hyperreflectivity in the outer nuclear, outer plexiform layer. Outer retinal laminations look fairly intact, and choroid looks good. I don't see any thickening. Looks fairly normal.
Excellent.
And but the inner laminations are kind of all gone, right?
Yeah, you definitely have. That's right. You have kind of loss of the interretinal laminations here, interplexiform, internuclear layer. Those laminations are very blurred.
It's all homogeneous internally.
Loss of definition there.
And here we have a OCT image, horizontal scan through the left eye. Infrared image looks fairly normal. You see that mild tortuosity of the vessels. Going to the OCT scan itself, vitreous looks clear. Interretinal laminations, when we compare this to the right eye, you see nice preservation of the interretinal laminations. Outer retina looks intact as well, and choroid looks normal.
So what would be your differential here?
Yeah, so the first thing that comes to mind with those dilated and tortuous vessels, diffuse intraretinal hemorrhages, central retinal vein occlusion is the first thing I think of. This he was 47, you said, so fairly young, which can make you think of, you can see this picture in hyperviscosity syndromes. Could think of hypertensive retinopathy. It is fairly asymmetric, so that would be atypical. You can see a similar picture in things like ocular ischemic syndrome, although you would expect to see more kind of mid-peripheral changes. These were kind of more diffuse, but you definitely can't rule it out based on our imaging findings.
But the vessels are usually non-tortuous dilated. So that's a difference there.
You could also, radiation retinopathy, that would be abnormal. You'd expect to probably see, and Dr. Shields, correct me if I'm wrong, you could see more retinal whitening and cotton wool spots in radiation retinopathy. So I'd want to know any type of medical history, recent radiation therapy.
There's this entity called papillophlebitis that was described by Shahlaee. That's basically a central retinal vein occlusion in young people. And lots of times that kind of goes away by itself and you don't find a cause. You can kind of see this too in young people that are marathon runners who get
Dehydration.
dehydrated.
I think if I have one differential here, CRVO, and then whatever is the cause of CRVO.
And is that entity papillophlebitis tend to be unilateral usually?
Yes. And it's self-limiting.
There's a little bit of inflow problem, as Carol mentioned here too. The arterial doesn't fill right away.
And just to get the retina opinion, on OCT there was blurring of the ganglion cell layer. Does that imply to you that there's ischemia, or what is causing that blurring? Because we're trying to make the differential here. Is there a arterial component to this?
mean, I would think it's more an ischemic component than anything else, but Jose?
I think anything that can cause the loss of normal laminations, whether it's edema, whether it's ischemia, I can't really be sure, because both can affect the normal laminations.
So retinal vascular etiologies were definitely highest on our differential at this point, and central retinal vein occlusion was kind of the highest. What other further points in the history would you think about for this patient?
Yeah, I mean, he's, like I said, he's fairly young, so I'd want to know more about his medical history, hypertension, diabetes, and then you think about, you know, hypercoagulable things, any family history of any hypercoagulable hematologic disorders, any recent illnesses, any history of malignancy. Those are the things I'd kind of ask him about.
Yeah,
Jose, what about sarcoid? Is sarcoid still in your differential here? Or?
Yeah, I think so, as well as things like syphilis, infectious causes. But what I think is important is, even though I mentioned the papillophlebitis, is because he is 47 and a youngster, like Dr. Sivalingam mentioned, this is one that's a field of dreams. You go the distance.
Right. So this patient had a fairly benign history, no real cardiovascular risk factors. His BMI was normal, no history of malignancy or radiation, no sleep apnea, no radiation, no family history of hypercoagulable states. He did report possible dehydration essentially the day before his symptoms. He was working on the lawn out in the sun, so he said he may have been dehydrated the day before, but notably he also got his second dose of his an mRNA-based COVID vaccine 2 days prior to the incident. I'll kind of jump to the workup that we did. So we kind of did pursue kind of relatively extensive workup, including hypercoagulability etiologies, which essentially all came back within normal limits. And kind of jumping to kind of the preferred practice patterns that the AAO has, the most recent version, they kind of identify some major risk factors for retinal vein occlusions, one being age, and they state more than 40 years. However, I know there is some debate on that, as well as some cardiovascular risk factors, sleep apnea and glaucoma in terms of risk factors for retinal vein occlusions, and some quote-unquote non-traditional risk factors for hypercoagulable etiologies for these patients. In regards to systemic evaluation, as Dr. Polito alluded to, there aren't very clear guidelines on when systemic testing is indicated. It kind of all depends on the patient's age, medical history, and kind of a discussion with the primary care provider in this regard. Dr. Polito, in this instance, would you have pursued systemic workup?
I think your systemic evaluation was perfect. And it is interesting about the COVID vaccine because you can't get that published in the literature. You have all these people saying, well, it's just, you know, happenstance. But I've heard this enough times in enough different conferences that I think that there is that possible relationship.
Perfect. And jumping straight to that, there's actually a number of case reports now out in the literature about COVID disease and retinal vein occlusions. As you can see, there are patients that are fairly young and sometimes even not hospitalized with some of what have no real risk factors in this regard. And there has been one case report of a central retinal vein occlusion after a COVID vaccination, also mRNA-based, in a patient had a lot of similarities to ours, 50-year-old, fairly healthy gentleman, had CRVO occurring immediately after the second dose. Hypercoagulability workup was unremarkable, but did have macular edema and was treated with anti-VEGF therapy with almost complete resolution of retinal pathology and complete visual recovery. There's a nice invited commentary just hot off the press just regarding causation versus coincidence regarding COVID and COVID vaccination. The kind of bottom line of it is we basically need more surveillance, more data through the clinical trials as to kind of come up with a causation versus coincidence and kind of get a more better understanding of this condition. But there definitely have been associations with both the disease and vaccine and some proposed hypotheses as to why this could be.
What I would like is the next time you see a case like this, to get that anti-platelet 4 antibody, because that has been associated with VITS, vaccine immune thrombotic syndrome, VITS. And so if you can show VIT, that antiplatelet 4 antibody with this, boom, there's a slam dunk. Lee Jampol cannot hammer you for that one.
So how long does that antibody, anti-platelet 4 antibody, stay in the system?
Not sure, probably a month or so.
Is he within a month?
He is past 1 month now.
I get it, though. Then we can then tell Lee, no, Lee, this is real. Sandy Brooker and I have been talking about trying to find a case like that.
So that anti-platelet 4 is seen in relationship to vaccines?
Yeah. It was originally found in patients that had heparin-induced thrombotic thrombocytopenia. So it's a rare disease. And now it's very commonly seen with VITS, vaccine-induced thrombotic syndrome.
And I kind of didn't jump into this in the interest of time, but my understanding is it's also been mostly associated with vector-based vaccines rather than the mRNA vaccines. So our patient 1 month after the initial visit had almost full recovery of his retinal laminations and full visual recovery without any symptoms. Left eye remained 20/20. Our third case, 20-year-old gentleman referred by his primary care physician for a dilated eye exam, patient completely asymptomatic.
So here we have a wide field pseudocolor image of the right eye. Vision is 20/20. The media appears clear. The disc is sharp, maybe about a 0.5 cup to disc ratio here. The vessels, at least in the near periphery and nasally, appear of normal course and caliber, though it's a little difficult to distinguish them out in the temporal periphery. Makes me wonder if there may be a little attenuated here. The macula itself is without lesions, no hemorrhages. However, in the mid-periphery, there are these pigmentary changes, looks like mixed areas of hypo and maybe some hyperpigmentation in the center here. There's another one over here in the far nasal periphery. And then really subtle pigment change right here might be something, though it's a little bit difficult to tell on the pseudocolor. And in the left eye, also 20/20, clear media opacity. Clear media without opacity. Sharp disc margins, again, about a 0.5 cup to disc. Again, you can see this nice, healthy retinal nerve fiber layer sheen, which was also present in the right eye, and no lesions of the macula. The vessels, again, are normal course and caliber nasally and proximally, but again, possibly some attenuation out in the far temporal periphery. And again, there in the mid-periphery, there are these mixed hypo and hyperpigmented lesions, which you can see here. They appear to be deep. There looks like there's a vessel overlying this one.
Looks like they have an equatorial distribution as well.
Yeah. This is a fluorescein angiogram of the right eye at 17 seconds. We can see pretty good choroidal fill, and I'll note that there's actually some hyperfluorescence out in these choroidal vessels, which is roughly in the area of the pigmented lesion that we had seen prior. Also in that area of subtle pigment change, there might be a little bit of increased fluorescence in that area, possibly a window defect or something of that nature. And with regard to the arteries, we're in the early arterial phase, and as of right now at 17 seconds, it looks like there's pretty good filling, but I'd like to see how it evolves. Here we are at 20 seconds, so slightly further into the arterial phase here. Again, you can see this marked, what appears to be likely window defect, though there's also this area that might be blockage, possibly corresponding to that area of increased hyperpigmentation we saw in the pseudocolor. Otherwise, really no flow deficits that I can see here. And out further, 1 minute, 14 seconds, it appears we're now in the full arteriovenous phase. Again, this hyperfluorescent area is still persistent with an area of blockage overlying. Now we can see out in the far temporal periphery, it looks like there's some attenuation and pruning of vessels, and the vasculature is starting to take on this kind of interesting sort of loop pattern, though I don't see any AV connections definitively in this frame here, and no leakage in this kind of middle frame.
Kind of get a glimpse of the nasal lesion here.
Yeah, perfect. So now we can visualize the other one that I had pointed out on the pseudocolor, again, showing maybe some hyperfluorescence here and maybe a little area of blockage. You can still see the vessel overlying it, showing that this is indeed a deep lesion. Again, persistence of the mixed hyper and hypofluorescent signal here. Good fill aside from the temporal periphery, but there's no vascular leakage, no macular edema, and the disc is quiet. And at 1 minute, 27 seconds in the left eye, we see somewhat similar findings to that of the right eye. Again, here these pigmented lesions again have mixed hyper and hypofluorescent signal, likely some blockage in those hypofluorescent areas. Again, it looks like the perfusion may be attenuated here in the far temporal periphery, and again, the vessels are starting to take on a bit of a loop sort of configuration. And then in the late frame, notable that there is no leakage, persistent, maybe staining here, and some window defect in those areas. And again, the vessel loops out in the periphery. This is a, it looks like an EDI OCT horizontal raster through the right eye. The IR reflectance looks grossly normal. And then the scan itself shows very well preserved lamination patterns throughout, good outer retinal lamination, and the choroid looks of normal thickness. And in the left eye, again, similarly normal appearing infrared reflectance here. And again, this looks like a fairly normal OCT scan. Maybe a little bit of thickening of the choroid here. I guess I'd like to know whether he might be hyperopic.
I don't have his refraction, unfortunately.
Fair enough.
What would be on your differential?
Yeah, so we have a fairly young patient, asymptomatic, with far temporal perfusion attenuation and these kind of mid-peripheral or equatorial pigmented lesions that appear chorioretinal. They're deep. Things that I would think about would be peripheral vasculopathies, things like diabetes, hypertension, though he does not show any of the other hallmarks of hypertensive or diabetic retinopathy. Sickle cell is known to cause peripheral vascular changes, especially in young individuals. I'd like to know maybe a little more about his racial background, family history of sickle disease or sickle trait. These multifocal pigmented changes, possibly with a thickened choroid, CSR, again, would be something that you could at least think of.
Sickle cell, what would you call those black lesions in the periphery?
Well, I know the hyperpigmented lesions in non-proliferative sickle cell retinopathy are usually referred to as sunburst lesions. Other things on the differential still, I think, less likely would be fever, which can have peripheral vascular attenuation, ROP, any history of that in infancy. And I think that probably sums up, you could also consider other inflammatory conditions like sarcoid, but I think those are probably all less likely.
Great, that was a really good list and description. I saw dengue fever sometimes in the chronic phases having similar chorioretinal lesions, although unlikely based on our patient's history, and ocular histoplasmosis. So the patient's history kind of made the diagnosis fairly easy for us. He was of African American heritage and had established SC disease and was being followed by his hematologist and was referred for an annual eye examination, essentially. So as we kind of were already talking about, sickle cell retinopathy is kind of categorized into non-proliferative and proliferative disease, with the non-proliferative having some hallmark lesions. The salmon patches are kind of these intraretinal lesions and hemorrhages that we can see. Refractile deposits or iridescent spots are basically sub-ILM depositions of hemosiderin secondary to hemorrhage. And sunburst lesions, as our patient has, are kind of these deep pigmented lesions associated with kind of resolving subretinal hemorrhage. And kind of given the atrophic nature of it, it would kind of be expected to have some window defect in addition to the blockage from the actual pigment, as we saw in our patient. In regards to proliferative disease, Dr. Goldberg came up with the staging for this, so 5 different stages of proliferative disease. And the importance here is kind of indications for treatment based on what stage the patient is at. So in non-proliferative disease, observation is usually the way to go. And in proliferative disease, mostly it's stage 3, low-intensity scatter photocoagulation to the junction of the perfused and non-perfused peripheral retina is usually what's recommended. And there is some literature mentioning potentially avoiding treating very large areas given that there could be potential risk of anterior segment ischemia. When would you consider doing laser therapy for sickle cell patients?
I usually don't treat unless it's active neo with vitreous hemorrhage. Then I would do sectoral PRP in those areas. But if you see regressed neovascularization where it's whitish, fibrotic, not bleeding, then those areas I leave it alone.
So if you saw a C-fan with no hemorrhage, you would watch?
Yeah, typically they can auto-infarct and they can regress by itself. So if there's hemorrhage coming down, that's my philosophy.
In England, they're much less prone to do laser than we are in the States. And the patients over there, they do, for the most part, relatively well. And I think now we've come a little less aggressive as well over on this side of the pond.
And would you treat the areas of non-perfusion completely?
Not necessarily. The way I do it, at least this is the way I've been doing it, if it's not perfused and there's active neo, and it's bleeding, then I'll go after it. But just because you have non-perfusion on the other side, I don't typically just do a panretinal photocoagulation.
Right, okay.
And, go back to the OCT. How old is this patient?
20.
20. So the question is whether there should be any nerve fiber layer temporally or not. And, it's always very attenuated, so it's always a difficult call. But it does seem like for a 20-year-old, that is thinner than the usual.
Yeah, that's a very good point. Okay, thank you very much, everyone.